Okay, guys, we're moving on to chapter 34, which is patients with special challenges. So this is going to be something where you're going to have to work with in EMS. You're going to see a lot of patients who don't fit like the typical classical mold, right? So we're going to talk about homelessness, poverty, bariatrics, which is like obesity, technology dependence, hospice, that stuff. Okay, so developmental disabilities, that is, official definition, I guess, is inability to learn and socially adapt at a normal developmental rate. And those things can be caused by genetics, birth, complications of birth, malnutrition, environmental factors. A lot of stuff comes from prenatal drug or alcohol use from the mom doing something, fetal alcohol syndrome, poisonings, all that good stuff. Okay, so basically, if they're developmentally disabled to a higher level, they really can't do a whole lot. On their own, they may need like at-home health aid kind of thing, because they may not be able to communicate or understand or do kind of those activities of basic or activities of daily living. They may not be able to do those. So now, of course, they're susceptible to all the same diseases everyone else is. They just have challenges. So autism, I think nowadays where everyone knows what this is. 10 years ago, I was still pretty confused, but now we got it. It's really just impaired social interaction. So, and now look, and they call it ASD, autism spectrum disorder, right? And it really is a spectrum. I've seen autistic students or autistic patients or whatever that are more or less normal. They can hold down a job, they can have a conversation, that they're, it's no real impact to activities they live in. But I've also seen on the other end some profound autism where they really can't. They can never hold down a job. They're going to have at-home health aid, the whole time. Like there's quite the big spectrum. And luckily, well, if it's a kid, you can talk to the mom, and the parents are going to know kind of where that kid's triggers are at. As an adult, hopefully they have at-home health aid kind of thing. So big wide range of disability with autism. Usually diagnosed by 3 years of age, and it affects males 4 times more than females. And that's, however, if they miss that diagnosis window, maybe they didn't have very good care, when they were younger, maybe it never got diagnosed, and then they grew up with it, and no one really caught on to it. Down syndrome is a genetic chromosomal defect that can occur during fetal development, okay? And that's things like enlarged protruding tongue, round head, flat occiput, slanted wide-set eyes. There is an increased risk for other medical complications. So as many as 40% have hearing vision problems, and 2/3 have congenital heart disease. So, and then also at the paramedic level, that Down syndrome is tough because intubation is that much worse, is that much harder to do, and as well as you may have to do the jaw thrust all the time just to really get that airway if they're on their back. So, and most of the time they're going to have some sort of parents or at-home health aid, and they're going to be able to assist with whatever you're doing. So all they're saying here is maybe you've never had to interact with somebody with Down syndrome like ever, and now you're interacting with them in a medical context. So yeah, it's totally normal to feel uncomfortable. It's a new thing, but just be calm and friendly, and explain what you're going to do, move slowly, be at eye level, just kind of the same stuff, the same consent stuff. Brain injuries, so same idea, where there's quite the spectrum of brain injuries. You could have maybe just occasional headaches or nausea, and then all the way to just terrible migraines with vomiting. So there's quite the visual impairment just means for whatever reason they can't see as well, and that either is entirely blind or just bad vision. But that can be congenital, it can be from injury, it can be just aging of the nerve pathways. There is also a range in blindness. So by that, I think the patient will be able to tell you though. So to make yourself known when you enter, introduce yourself, understand the patient might be feeling pretty comfortable and afraid. So just keep that in mind when you're talking to them. And then communicate obstacles in advance when you're guiding them along or out of the house or whatever you're doing. So for our hearing impaired patients, luckily they, at least a lot of the hearing impaired patients I've had to work with, they're no real different. Other than they can't hear, but other than that, they figured it out. They're doing sign language, or they have their method for communicating, and it's really no impact on their anymore. So those are just a few different types of hearing aids, just so you know what they look like. If you have to, you can piece of paper and pencil, right? Do whatever works, whatever that person wants to do. Do not exaggerate lip movements or look away. If they're lip readers, they can do it at normal speed. And if anything, if you're slowing them down, it can be kind of weird and it's not unnecessary, right? So just talk to them. And then there you go. The patient's going to know how they want to communicate. So just ask them, how would you like to communicate? Okay, hearing aids. Yep, you know that. Okay, cerebral palsy. It's basically poorly controlled body movements. It can happen from damage in utero. It can happen just from a head injury itself, postpartum, and there's a few things that can do it. A poor posture, uncontrolled spastic movements of the limb, difficulty communicating, and sometimes they'll have visual and hearing impairments as well. They also are going to have seizures. They could have some sort of developmental disability. They may not be able to walk, so that's why a lot of them have the little mechanical walkers. So don't always assume it. Some people with cerebral palsy have totally normal functioning brains. So don't necessarily assume that, oh, he's cerebral palsy, so I'm not going to be able to communicate. So never force extremities into a position. Try to take the walkers and wheelchairs with you when you go. All right, Spina Bifida is a neural tube defect, and this is basically an incomplete closure of the spinal cord from birth. It can be corrected surgically, but there's still some damage that remains, okay? And so you can have hydrocephalus, partial or full paralysis of some extremities, loss of bowel, bladder control, and even sort of an extreme latex allergy. All right, paralysis just means they're paralyzed. They can't move a certain part of the body. That can be from stroke, trauma, birth defects, whatever. And they may have to be using some of these devices: urinary catheters, tracheostomies, colostomies, feeding tubes, all that stuff. Each type of spinal cord paralysis requires its own equipment and may have its own complications. So this is one of those ones where you want to get a really good history on the cord damage that you go through. All right, bariatric patients, obesity basically, which is about 20 to 30% over ideal body weight. It is said now that 2/3 of America is overweight or obese, so this is definitely not something that's going to go away in our lifetime, unless there's some major drastic change to our society. It is complicated, I will say that. Just everything's more complicated. You have to potentially use a different stretcher. Maybe the person can't actually be exited from the house in all doors. There's only like one door that had to get widened, or there's things like that. And yes, they are ridiculed and they have some anxiety with it, and their quality of life would be negatively affected. And sometimes with this morbidly obese patient, you have comorbidities like diabetes, hypertension, heart disease, stroke. If they are morbidly obese because they have like a food addiction and they're just constantly eating whatever, well, it makes sense that they might have high blood pressure and heart disease and diabetes, right? Because they're not necessarily eating healthy when doing that. So, yep, the patient might feel embarrassed or ridiculed, and that does not why you're there. You are there to treat that patient with respect and treat their injuries and everything. So try to keep that in mind. And once again, is kind of a common thing in this chapter is ask the patient, if you're trying to move, how would you like to move? Usually the patient knows what's best for moving around. If you're doing like a few people doing a lift, control is always the thing. So if there's at any point it becomes uncontrolled or a little bit weird, just stop, restart, do it again. It's not worth trying to just hoof it and then have an injury or something. And there are some specialized equipment for these bariatric patients. Okay, so these are the things we talked about earlier, some of these advanced medical technology devices. So we will talk about all these. So tracheostomy tube it's a tube that's placed in the neck. It can be temporary or permanent. And it goes directly into the airway, and that is something you might see with patients who have a chronic pulmonary condition. They're on some sort of ventilator. There you go. Unfortunately, that the body doesn't know what is going on with that, so it builds up a bunch of secretions. So unfortunately, tubes can get obstructed by mucus and foreign bodies, and it can even potentially, if it blocks the tube, the person's breathing. So this is something we can remember for if you're got called for a tracheostomy tube malfunction. You can think of DOPE, so displacement, dislodge, damage. Something's not right with the tube itself. there's an obstruction in the tube. Maybe this person's breathing issues has nothing to do with the tube at all, and they actually have a pneumothorax, and then or equipment failure, and that's something like a ventilator fail, something like that. So those are some common problems that you might see. Basically, suction, 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 suction. Most of the time, any sort of tracheostomy issue can be solved with suction. Okay, mechanical ventilators. So that is when the patient is breathing is actually regulated by a machine. And that can happen from lung disease, congenital defects, traumatic brain injury. It can happen from a few different things. If a ventilator malfunctions, you now become the ventilator. Okay, so disconnect them from it, and now you're back valve. Now you are using the BVM. If depending on the ventilator they have, you can look at the settings, and it might even tell you how many milliliters from each in each breath and stuff. So if the ventilator goes down, your hand now becomes the ventilator. Okay, so there you go. The patient's caregivers should know how those things work. So just be familiar with kind of turning on and off in that process. Okay, so apnea monitors are for infants who are premature or they have some sort of severe GI issue, family history of SIDS, and some other threatening event. So use 2 weeks to 2 months after birth, and then just monitors respiratory system. If anything weird happens, it sounds an alarm. So it provide a pulse oximeter reading and bring it with you. If you ever encounter that, bring the apnea monitor with you to the hospital. All right, an internal cardiac pacemaker is what it sounds like. It's an artificial heart, basically. Something's wrong with the heart in the patient. The electrical system may not be working and there's damage to it. So a pacemaker takes over that. There you go. On this left ventricular assist device, it is what it says it is. It helps the left ventricle. It assists it with that process, with the heartbeat process. So you might both those. All right, central venous catheter is usually used for home care patients. So you might see in the chest, upper arm, or subclavian area, and that's kind of like a central line, and that's just a guaranteed way to access the vascular system. So there you go. It might look like something like that. However, you could have broken lines, some clotted lines, and bleeding around the line, and those can malfunction. Gastrostomy tube, it's directly into the stomach for feeding, for people who cannot ingest anything by the mouth. There you go. Okay, may become dislodged, and you're looking for these signs and symptoms of that maybe something is wrong, especially with that vomiting, and the vomiting up blood is a pretty good sign that maybe something wrong with the stomach. And there's also an increased risk of aspiration, right? Because they vomit, they get it in, now they're in trouble. A shunt is basically something for a chronic neurological condition that it extends a tube from the brain to the abdomen to drain excess CSF. So there's a few different types of shunts. At our level, it doesn't matter, just want to know what shunts do. They help keep pressure low in the skull. So the CSF starts to build, and those shunts help remove that. So blocked or infected shunts could do a lot of damage in patients. Be real careful with these. If we have an infant with a shunt, we're looking for those bulging fontanelles. If that head starts to swell on top, then we can assume that there's a buildup of CSF. A patient might have a headache, projectile vomiting, altered mental status, irritability, all that stuff. Blurred vision, all of those things. Seizures, even bradycardia, heart arrhythmia. So like I said, if a shunt goes wrong, there's a lot of stuff that can happen. So if you're thinking that that's a shunt malfunction, this person needs to go to the hospital right away. Vagal nerve stimulators, it's an idea, it's an alternative to medication, and there's some research that says that it's going to prevent seizures from happening. Use in older children under the skin, about the size of a silver dollar, if you guys even know what that is. And this is a local protocol issue, so if you encounter this, I would call control and see what's going on. Colostomies and lleostamies are basically something that assists with the digestion. Okay, so if you see any of these signs and symptoms on the exit, on the stoma, which is the opening, redness, warm skin, anything like that, you can assume there's potentially infection in there, and that's also a big deal. So basically with all these things, all these devices we're talking about, if there's something wrong with those devices, take them to the hospital. Those are in some cases life-saving devices, and they need to be fixed. So home care, we're just talking about some of the things to think about with some of these patients. Is is are they really old? Are they really young? How do they cook? How do they clean? Laundry, physical therapy, all that stuff. You may be called by one of those at-home health nurse type people to cover, and they're going to be your best asset for that situation. Now, hospice is just terminally ill may receive hospice care, which is basically just end-of-life care. They may or may not have a DNR order. You need to look into that. And every state's going to handle this a little bit different, but the idea is it's basically comfort care. It's pain medication and just really trying to improve that quality of life in the last few days. Follow local protocols, though, when you're dealing with one of these hospice patients. Allow family members to transport the patient if you're deciding to transport the patient. Let the family come. And last thing is going to be that poverty and homeless. That's a special population in EMS. We are going to encounter that a lot. They're basically, the big deal there is disease prevention strategies. And a lot of homelessness is related to, it could be some sort of mental illness, domestic violence, drug addiction. It's bad overall. So we really, what it comes down to there is that last bullet is social services and social resources that might help that patient out. There's not much you can do as an EMT in the back of an ambulance, but if you're aware of some social services that would assist that patient, then you're doing your job. Okay, so with that was a down and dirty, real quick lecture on our special patient populations.